Hi, good morning, friends. Happy Sunday, and this is Colonel Pradeep Pindyala, Professor of Anesthesiology. Today I am going to talk about ECMO, extracorporeal membrane oxygenation. Then, extracorporeal membrane oxygenation is very important and everybody should know, especially doctors, anesthesiologists, and people working in critical care medicine. The first thing which comes to your mind when you talk about ECMO is the recent happening of the greatest singer S.P. Balasubramaniam, who was put on an ECMO for very long, and there was a news also just before his death that he's likely to be taken off from ECMO, but unfortunately it never took place and we lost him. But don't be disheartened, friends. The success rate is very, very high. For a recent example, one of the anesthesiologists, I won't like to name him, he was on ECMO for long after COVID complications, and subsequently he had lung transplantation and he's very much survived. Without the lung transplantation also, the success rate is very high, especially and survival to hospital discharge is around 40 to 50%. And if the ECMO was used for the reasons of myocarditis or post-heart transplantation graft failure, the success rate could be around 75%. It's really very, very interesting. And when we talk about ECMO, it's nothing but it's an acronym of extracorporeal membrane oxygenation. And you must know that in severe pulmonary hypertension also it could be used safely. The mainstay of rescue, especially in congenital diaphragmatic hernia patients. And you must know what are the criteria for starting ECMO when in such patients, when there is inability to maintain pre-ductal SaO2, that means saturation more than 85% and post-ductal saturation more than 70%. It's one of the indications, the criteria for starting ECMO. If acidosis is less than pH 7.15, we have to start. And if the lactate level is more than 5 millimole per liter, we may have to start ECMO. Oxygenation index is more than 40 for a defined period and more than around 24 hours, then if the oxygen index is persistently more than 40 for 4 to 6 hours or maybe more than 1 day, then we have to think of starting extracorporeal membrane oxygenation. Besides that, if there is systemic hypertension, which is resistant to fluid and inotropic resuscitation, that time also we may have to think about. Despite inotropic resuscitation, if the urine output is persistently low, lower than 0.5 ml per kg per hour for more than 24 hours, we may have to resort to ECMO. And when the peak inspiratory pressure is more than 30 centimeter of water or mean airway pressure more than 17 centimeter of water, and that is required to achieve just around 80 to 85% of saturation, that is the time we may have to resort to ECMO. Fine, let me explain it a bit more about ECMO. It's a modified heart-lung bypass machine. If you want to know what is ECMO, in short, you have to know it's nothing but a modified heart-lung bypass machine. It has a centrifugal pump, heat exchanger, and a membrane oxygenator. Venous blood is normally aspirated from the right atrium into a centrifugal pump, and normally the cannula are inserted into the right atrium via the femoral vein. And Returning of the circulation usually takes place via the femoral artery. There are usually two types of ECMO. VA ECMO, that means veno-arterial, and VV ECMO, veno-venous ECMO. Now, let me tell you something more about ECMO. ECMO is definitely very useful in cases of ARDS, acute respiratory distress syndrome, especially VV ECMO is primarily used. So that is it. And the oxygenator is placed normally between the outflow cannula, which is usually internal jugular vein, and inflow cannula, that is femoral vein. Usually there is no pump, and the patient's cardiac output itself is the driving pressure used in ECMO. And oxygenator and gas exchange, that's how it takes place, occurs once the deoxygenated blood is formed. It is normally returned via the pulmonary circulation to the left heart. Now, could there be any contraindications for ECMO? Yes, there are contraindications, especially when the expectancy of life is very short due to malignancy or other terminal diseases. There is no point putting person through ECMO. Is there any complications of ECMO? Yes, there are definitely. Similar like inflammation, renal failure, ischemia, and there could be bleeding. And the basic ECMO, as I had mentioned, has oxygenator, heat exchanger, and venous and arterial cannula are used. And arterial blood sampling, when you have to do while ECMO is being used, you have to take the sampling from the right upper extremity. Usually the peripheral cannulation can have risk of ischemia, limb ischemia, so you have to be careful. ECMO requires anticoagulation. When you are using ECMO, anticoagulation also has to be used in the form of heparin. And when you are using heparin, the activity clotting time should be 1.5 to 2 times the normal. Okay. And once adequate oxygenation saturation, once oxygen saturation is perfect, mechanical ventilation is normally reduced or lungs are given a rest by decreasing the tidal volume, decreasing the respiratory rate, and decreasing the peak inflation pressure, and by the use of PEEP, positive end expiratory pressure. Incidentally, there could be hypotension, which may be treated with while using ECMO. That has to be treated with norepinephrine. May be required, norepinephrine may be required to treat hypertension. Hypertension is usually supported. It may be caused because of hypovolemia or reduced vascular tone, or it could be because of myocardial dysfunction. So accordingly, we have to treat the complications while using ECMO could be patient-related or machine-related. Machine-related. Patient-related are normally coagulopathic bleeding and hemodynamic instability or sepsis or intracerebral hemorrhage. And this could be treated. Hypertension, I mentioned, it has to be treated with norepinephrine. Well, that was that, but success rate is definitely very high. I hope I made it very clear. Have a wonderful Sunday. Take care. Happy Sunday. This is Colonel Pradeep Pindyala Professor of Anesthesiology, signing off for today. Take care. Until next time. Bye bye.